Deposition of plaque in a blood vessel. Which area? In the internal. Anybody else? Yes. And it is in between. Exactly. This is important. Remember, when we talk about atherosclerosis, means we are talking about something which is accumulated between internal elastic lamina and endothelium. So that area is called intimal. It never passes down into media, right? So before actually we go to the topic, let's see one by one the learning objective, that is define atherosclerosis and monkey-bug medial calcific sclerosis, fibromuscular intimal hyperplasia, and arterial low sclerosis. Describe pathogenesis of atherosclerosis, including role of endothelial cell, smooth muscle cell, macrophage, platelets, and other factors which is present in the plaque. Then list of risk factors which actually helps in forming that plaque. Then we have definitely morphology, gross and microscopic, so you have to know about it, of the atherosclerotic plaque lesion and different stages. So we will show you the gross and microscopic picture of the different stages, and then finally describe natural history and complication of the atherosclerosis. This, yes. That will be even better if somebody please. Is it clear?
It's over there in the corner.
Please, can somebody close that light? So before going to the main atherosclerosis, let's see the normal arteries. How does they look like? If you see here, these are the arteries and these are veins. These are large arteries, these are medium size, and these are small arteries, arterioles rather. These arterioles, you all know that they are usually used for maintaining the blood pressure, right? The larger arteries, especially aorta and the main branches, they are mostly elastic arteries. They don't have only the smooth muscle, but they have abundant elastic fibers. And that elastic fibers make the large artery flexible. Just imagine a heart pumps and it gives out blood which is of high pressure, and these vessels, they bear that pressure and then it supplies the whole body. So they had to be not only muscular, but they had a good portion of elasticity. Then we have muscular one, which is medium size. Mostly they are muscular ones, and then a small one. If you compare arteries with arterioles, you can see how thin the wall is as compared to the artery. Even in the larger one, you can see only a small amount of smooth muscles. Now this is a diagrammatic picture. Now if you see under microscope, this is a real picture. In this section, you can see a large artery and a large vein. The large artery, the wall is so thickened. This is intima, this is media, and this is adventitia. In vein, you can see hardly a small amount of media. So intima, media, and so thin as compared to the artery. Clear? These are arteriole. These are arteries, larger one, arteriole, yes. Again, the arteries are thicker as compared to the vein. What is this? This is nerve. It is a cross section of a nerve, right? So now you are well familiar that the arteries are thicker and the veins are thinner. Okay. So arteriosclerosis, there are multiple different terms. You had to learn that. Very, very confusing sometimes. Arteriosclerosis, This means sclerosis means hardening. Sclerosis means fibrosis. Sclerosed, fibrosed. And whenever the thing is fibrosed, it is hard. So hardening of the artery is called arteriosclerosis. Simple. So basically it's a hardening of the arteries. So what happened? The generic term reflects the arterial wall thickening and loss of elasticity. So as the blood vessel become hard, the elasticity of the blood vessel will be lost, which is really important, right? During the age process, usually what happens, the arteries become less elastic. And you have seen the patient after 50-55 years, usually who are normotensive, slightly start developing blood pressure. And this is the reason why, because the arteries are becoming little harder. They are not that much flexible when it was when they were young, right? So there are 4 different clinical or general patterns, and we will see it one by one. One is arterial low sclerosis. So there is a difference. This is arterial sclerosis. This is arterial low sclerosis. Means we are talking about a small artery, arteriole and arterioles probably. We are talking about arteriole. So if the sclerosis of the arteriole, the smallest one, we call it arterial low sclerosis. Number 2 is Monckeberg medial sclerosis. As the name says, medial means whatever things are going in is in the medial. It's not involving the intima, neither in the interstitial. So media is involved. So Monckeberg medial sclerosis. The third one is fibromuscular intimal hyperplasia. Again, the thing is again clear here. That whatever we are talking about intima. Intimal. So media is not involved, only intima is involved. And finally we have atherosclerosis, which is a topic of today, and we'll discuss it very briefly, not briefly, but you know. So these are the 4 things, and we'll take it one by one. Arterial low sclerosis. So it affects small arteries and arterioles, as the name says, with the thickening of the vessel wall, and may cause downstream ischemic injury associated with hypertension and diabetes. So usually they have seen that in diabetes, this arterial low sclerosis take place. There are 2 types. One is hyaline and the other one is hyperplastic arteriosclerosis. In hyaline is this one. This is hyaline. This is hyperplastic. In hyaline one, what happened? Anybody? There is accumulation of hyaline material. This is hyaline is a proteinaceous material. So hyaline arteriosclerosis, wall thickened with the deposition of amorphous proteinous material, which is hyalinized. So by deposition of this hyaline material, the vessel lumen become narrowed down and hypertension develops. And usually this is seen in essential hypertension or benign hypertension, right? The other one is hyperplastic arteriosclerosis, hypoplastic. As the name says, there is hyperplasia of the muscles. And you can see that there is onion skinning. What is onion? You have seen onion in your kitchen. And if you cut it, you see words, right? It is just like this, onion skinning. And the lumen is so small. Usually you see this thing in malignant hypertension, right? Because the lumen is so small, artery is so hard, hardly it allows the blood to pass. So the blood pressure remains high, malignant hypertension. How it is controlled, how it starts, it's a condition who will get you there, right? But as a pathology, you must know that in malignant hypertension, you usually see onion skinning of the arteriole. Okay. Now coming to Monkeyberg medial calcific sclerosis. Very big name, but the function is very small. Again, medial means something happening in the medium. Calcific means some calcification is also going on. So the thing is also being told in the name, the vessel which we are talking about. What happens? This Monkeyberg medial sclerosis is characterized by calcification or calcific deposit in the media, means it is behind the internal elastic lamina, or it is in between the internal and external elastic lamina. It is encircling, right? But it usually happens after the age of 50. But as it does not cause any encroachment into the vessel lumen, there is no clinical significance. Although the name is so big, but the clinical significance is zero. Only when you see under X-rays or accidental finding, you see Monkeyberg's medial calcific sclerosis. Clear? Where do you see normally? You see in older ladies after menopause, in the uterus, right? The vessels become calcified, but it does not create any problem to the uterus. Okay? Clear? This is how it looks like. You see, with the big lumen, no problem in the lumen. There is a lot of calcification in the media. Intima is not involved, adventitia is not involved, but only the media, which does not even causing obstruction in the lumen. Clear? Okay. Then comes the fibromuscular intimal hypoplasia. Now, as the name says, fibromuscular intimal means something is going on in intimal. So it's a fibromuscular intimal hypoplasia is a non-atherosclerotic. Remember, as some of your friends said, that atherosclerosis also involve intima, and this is also in intima. There should be some difference. The difference is atherosclerosis is not involved. Means you don't have any lipid in the intima. Although, and usually it involves the larger arteries. This is predominantly a smooth muscle cell and extracellular matrix lesion. Means they are proliferating and they are been arranged in the intima. So it is in between the interelastic lamina and endothelial cells. Now problem is that it starts doing it when you do some mechanical action there. When you, the student, sitting there, this entity was not there about 30 years ago, 35 years ago, when we were students. Because at that time, intervention was not usually been done. It was just introduced at that time. But now it is a regular process. Angiography is done very frequently. So now they have noticed that those patients in which angiography is performed and balloon angioplasty or stent are being placed, they cause damage to the coronary artery or even any other artery, popliteal artery. Suppose if I put stent in the popliteal artery, this will start there. Such a healing response can cause substantial stenosis. So this is important. So what happens, suppose if you have a stent inside? So it will start proliferating, and maybe both of the end where the stent is there, probably it will not block, but the area before and after can be blocked. So it will look like this one. This is all intima. This is media, which is pink color. This is adventitia. So this intima, you see how much thickened this intima, and it has actually narrowed the lumen, right? So that it has an importance. So I have just kept one picture, which is a normal artery, so that you can see, you can hardly see a intima here. This is all media. Intima is just thin area. But you can see here how much big intima is here. This is a proliferation of smooth muscle cells and extracellular matrix without any. You can have inflammatory cells here, yes, but no lipid will be here, which is a core thing in atherosclerosis. Okay. Finally, atherosclerosis, which is a topic of today. They are characterized by formation of intimal lesion called atheroma. There are different names for this atheroma. Sometimes, because when you are reading book, sometimes it is written atheroma, sometimes it is written atheromatous plaque, sometimes it is written atherosclerotic plaque. So this is all one and the same thing. Don't be misguided. Atheroma, atheromatous plaque or atherosclerotic plaque is one and the same thing. Now they protrude into the vascular lumina and can rupture to cause sudden occlusion of the vessel and thrombosis. So not only it is coming up, it is occluding the vessel wall, but also what is going on, it is sometimes when it is ruptured, a thrombosis can come up into it. It is a primary chronic inflammatory disorder of elastic, large, medium-sized muscular arteries that result in progressive accumulation of fibrofatty plaque, which is atheroma, within the intima, and it's composed of core of lipid and fibrous cap. So, let me ask a question here. Yes. So, this atheroma is composed of? I didn't say that. I just took 2 minutes. What are these? Number 1. Because you are busy in your mobile. And remember, if anybody busy in mobile, I can directly throw a question to them. I need full attention of yours here. You can stop me, ask question. But if you play with your mobile, you will get a question. Don't do it next time. So, this atheromatous plaque has a core of lipid with a fibrous cap. Core of lipid, it could be either foamy macrophages along with the lipid or smooth muscles, inflammatory cells, and they had a core of the fibrous cap, which is formed by smooth muscle and extracellular matrix. Clear? Good. So this is how it looks like. This is a normal looking blood vessel. Just to show you how the things will come up. This is intima, endothelial cell lining. Then we have a small space. This yellow space is intima. And then this is internal elastic lamina. So the thing is in between internal elastic lamina and endothelial cells. So what a small space we have normally. A huge space of media. Now this media is bounded by internal elastic lamina and external elastic lamina. Clear? Then we have adventitia, in which we have many other things. Along with this, we have blood vessel. What this blood vessel are called? Vasa vasorum. Why they are called vasa vasorum? Because they are vasa, blood vessel. Vasorum means supplying the blood vessel. Vasa, vasorum. Blood vessel supplying the blood vessel. Right? This is a normal structure. Can we have blood vessel inside the wall? Can we have inside the wall? No, normally we don't. But in atherosclerosis, we do have this. Right? How? We'll see. So now if you see here, this is called plaque formation. We have lipid, we have cholesterol, we have foamy macrophages, we have smooth muscles, we have inflammatory cell, macrophages, lymphocyte, and we have blood vessels at the end. We have extracellular matrix, elastin, protoglycan, and new vascularization. Why new vascularization? because this intima, which was just this much thick, very thin, right? Now it has become that much thick. This much thick intima needs excessive blood supply. So many of the growth factors start coming up. Platelet-derived growth factor, transforming growth factor, they start proliferating the blood vessels. So newly formed blood vessels are formed, and due to this newly formed blood vessel, this all area is being additionally supplied by the blood. Clear? You can stop me anytime if you feel like you have not understood. Please. I have no problem in repeating again and again. There is no lecture after this one. So I can even take 2 hours if you want.
We have a lecture.
No?
We have.
Dr. Gowans?
Yeah.
In my schedule, this is
Yeah, it was 3
oh my God, he will be standing there. Oh. I thought that's why I was a little slow. Yes.
Can you just repeat why the blood vessels are formed?
Why the blood vessels are formed?
Yeah.
Because there is a huge place here. They need nourishment. As I said, vasa vasorum basically was supplying the outer 2/3 of the blood vessel wall. The inner 1/3 is been nourished by the lumen blood. So as the lumen is here, and now we have a lot of distance. So we need nourishment, blood supply, oxygen for this area. So newly formed blood vessels are formed. Okay? So I had to be a little faster then. I thought there is no, really, that's why I was a little slow. Lucky, I will not throw questions there. Okay, so component of atherosclerotic plaque. We have already seen that component. It's just a revision. Cells, smooth muscles, macrophages and leukocyte. But the main cell is endothelial cells. Endothelial cell has to be damaged. Otherwise, endothelial cell has a capacity, it does not allow anything to pass through, right? You know that. Then connective tissue, extracellular matrix, which is collagen, elastic fiber, proteoglycan, and then intracellular, extracellular lipid deposits. You know. So all the 3 components occur in a varying proportion in different plaques, giving a spectrum of lesion, right? And we can see again the same picture, and these are all which we have discussed already. Now, atheromatous plaque usually involved in the descending order: lower abdominal aorta, coronary arteries, popliteal arteries, internal carotid artery, and circular venous. So this is how, in a descending order, this is the sequence of atheromatous plaque. Okay. Then risk factor. So there are 2 major. One is non-modifiable and the other is modifiable. Why we call it non-modifiable?
We can't change.
We cannot change. And modifiable?
We can.
We can. We had a chance of dealing with that. Non-modifiable are genetic abnormality. Genetic. One is born with a genetic problem. We cannot help it. Right? Somebody has hyperlipidemia, familial hyperlipidemia. And those people, they have seen that atherosclerotic plaque has developed in the age of 20 even, because they are developed or they are born with the genetic problem. Family history. Some of the families has hypercholesterolemia or suppose diabetes or something else. Family history, we cannot stop it. It can be there. Increasing age, every day your age is being increased. You cannot stop increasing your age. Huh? Or you can have Abe Hayat. Even then your age will be increasing. So age, after the age of 40 or 50, atherosclerosis becomes more common. Right? And then finally, gender. Male are more affected than female. They used to say in the reproductive age, the female have estrogen hormone, which actually helps not to form sex hormone, right? But after menopause, male and female become equal, or probably female are in a more problem than male. And in their research, they have seen that they have given estrogen, exogenous estrogen to the female, which does not help. Which does not help in protecting that. Means the estrogen they were producing inside during reproductive age was really helpful, but exogenous estrogen was not helpful. Modifiable one, hyperlipidemia, you can modify. You can stop eating lipid things more in your life, right? Junk food. Huh? We have just go in a ground floor, food street, KFC, Kudo, McDonald's, you see and then you have it. And the problem here, we eat a lot, but we don't exercise. Yes, if you eat and exercise, no problem. But here, if we have to, even, if you ask me, this mosque is not far, the main mosque outside the university. I'm not talking about the inside one. Go and have a prayer. Probably I'll take my car and park it there. So the habit of exercise is becoming down. Right? This causes hyperlipidemia. But nowadays statins are there. You can give statins which can control LDL level. And they have seen that after taking LDL, or if they drop the concentration of LDL in the blood, that maintains forming atheromatous plaque. Means atheromatous plaque are not formed in the person who are taking the statins. Hypertension, definitely hypertension is one of the cause, but if you give a good medication and maintain the normal blood pressure, for example, if the person has 160 by 90 and you give a good medication and that person's blood pressure remains 120 by 80, remains, means now he is not hypertensive. You can save your endothelial damage because hypertension is a major cause of endothelial damage. Cigarette smoking. Cigarette smoking, I've not seen girls, I've seen many of the boys smoking cigarette. You can stop smoking cigarette. Because if you stop smoking cigarette, you are not helping anybody else, but you are helping yourself. I remember one friend of mine, he has died now. He was a chain smoker. 2 packets a day. I always used to say that please stop because of my age. Nothing happened. Please. You're a doctor, you always. He is no more with us. So, stopping cigarette is not, and then what? At the end, what you said? Oh, this is Almighty Allah. It's not Almighty Allah. It's you yourself. You are smoking and you are blaming Almighty Allah. No. So if you stop smoking, atheromatous plaque will not come. Diabetes. We have some families in which diabetes plays a role in. So for suppose if you have a family, your father is diabetic, mother is not. If your mother is diabetic, father is not. Or if both of the parents are diabetic, then you are sitting in a war. You have to be careful right now at this age. Stop taking sweet things. Stop taking the lipid-rich thing, right? Do more exercise, and inshallah, if you have both parents, for example, my mother was diabetic. I was very careful. I don't take extra sweet things. Although I have gained little weight now, but I'm still struggling in coming back. So this is how you can, at this age, if you make yourself fit, at my age you will be fit at all. Okay. Additional risk factors: inflammation, very important. They have seen that inflammation is always present around the atheromatous plaque, and this is one of the reasons why it's there. And what test do you see inflammation? You remember? Yes. ESR or CRP? Yes. And CRP is usually a protein formed in the liver, but you can see the CRP forming at the site of inflammation. So they have seen that atheromatous plaque people have raised CRP levels. Hyperhemocystinemia. This is inborn error, and those people who have more hypercystinemia, they develop more atherosclerosis. Metabolic syndrome, central obesity. As I said, if you don't have exercise a lot, the things will be accumulated around the abdomen, and central obesity. Then you have insulin resistance and ultimately diabetes. So it's a vicious circle. So you have to be very, very careful not to form this central obesity. Lipoprotein A. This is also one of the factors which you can stop, and if you give treatment, you can withhold that. So those who had high concentration of lipoprotein A may develop more atheroma. Elevated level of procoagulant, coronal hematopoiesis, or physical inactivity. This is what I'm saying. No exercise, sitting in a chair, doing their work, hardly move around. And stress, type A personality. You know what is type A personality? Always enthusiastic. Do this thing, this thing. These people are really very smart. They used to do their work before time. And they are always on their toes. And they are type B type of personality. They are happy-go-lucky. Least bother. When the time comes, we will see. But the type E personality, they are very enthusiastic, always prepared. No. So they usually take more stress. Okay. So this is one picture just to start with. That this is intimal and this is smooth muscle cells going here. And this, remember, this smooth muscle is not the same as this smooth muscle. When this smooth muscle crosses this line, they are changed smooth muscle. Now they have a capacity to secrete extracellular matrix, which this smooth muscle doesn't. It can come from the lumen as a precursor smooth muscle directly inside. They can take it from here. Then they start secreting this extracellular matrix and start forming this atheroma. Now this response to injury hypothesis, which is atherogenesis, they said that this model view atherosclerosis as a chronic inflammatory and a healing response of a arterial wall endothelial injury. So chronic inflammation, endothelial injury clicks one another, right? How? The lesion progression occurs through interaction of modified lipoprotein. Modified lipoprotein means oxidized. As they come in, the cytokines modify that lipoprotein to produce oxidized lipoprotein. Then this lipoprotein, oxidized one, they push macrophages to become activated macrophage, and this vicious cycle start going on. And this activated macrophage then start secreting cytokine like interleukin-1 and tumor necrosis factor, histamine. They go up, they stimulate endothelial cell. And what happened to endothelial cell? Remember your POD lecture, inflammation. You have to take cells in. What will happen? Someone book one from you. My POD lecture, I taught you. Okay, that's why I have captured that slide and I'll show you here. So the lesion progress, modified lipoprotein, macrophages, lymphocyte interact each other, right? So what happened then? Again, you need, what happened? You had to have a chronic endothelial injury, number one. Accumulation of lipoprotein in, once the endothelial cell is injured, it allows the lipoprotein to come in. Monocyte adhesion to the endothelial migration, it will go down inside. Then we have platelet adhesion on the surface, lipid accumulation in the macrophages, inflammatory cytokine release from the macrophages, as I said, interleukin-1, tumor necrosis factor, other growth factors which will actually activate the smooth muscle cell to proliferate. Smooth muscle cell recruitment from the lumen as a precursor smooth muscle, or from the media come up, but that will be changed one. Smooth muscle proliferation and extracellular matrix production. Now this activated smooth muscle, activated by macrophages, the growth hormones. Now they are started proliferating itself in the media, in the intima, and then lipid accumulation there. So this is how the things are going on. You have to have a chronic endothelial injury first, number one. Without that, nothing will happen. And which will cause endothelial injury? Hyperlipidemia, hypertension, smoking, homocysteine, hemodynamic factor, toxins, viruses, immune reactions. We have discussed already, right? So these all things cause endothelial injury. Once the endothelium are injured, what will happen? This will happen. And this is the slide from your inflammation POD1 to recall your knowledge. If you see here, should I come here? If you see here, these macrophages, they are secreting TNF and interleukin 1. This is the same lectures which we have already done. This interleukin 1 stimulate endothelial cell, P-selectin and E-selectin, right? Now this actually start attracting, here it is neutrophil, we have monocyte, right? There is a difference. Initially, in inflammation, neutrophils come first. But here, why we have monocyte first, I will tell you later on, right? Just understand this process. Then, chemokines come, go up. We have here integrins which in a low affinity state. And when this chemokine attaches with them, what will happen? Become high affinity. And then they strictly attach to the endothelial cell, ICAM, and then through PCAM, they comes out. So this is what we have done already in POD block. Go and open that one, that will refresh your knowledge. Right? That's why I've taken just one slide. So what happened? The same thing is happening here without this whole cascade. So then, once the monocytes are down, there is increased permeability, leukocyte adhesion, monocyte adhesion, and immigration comes down. Secondly, macrophage activation and smooth muscle recruitment, second phase. Now the smooth muscles are coming either from the media or from the lumen. Clear? Please stop me if you are not understood. Huh? Yes. Yes. This one. This is first. This is first? Okay.
Can we say that the ROS agent also play a role in the
Which one?
The ROS agent.
Reactive oxygen species.
Yeah.
Yes. It can. This is what. Then I have to go back. Where is inflammation? So inflammation usually secrete ROS, reactive oxygen species. This is one of the reasons which damage this endothelial cell. Yes. Okay. Now macrophage and the smooth muscle cells are here. They are activated, and what happened? They are the lipids are being taken up by macrophage and smooth muscle cells. Like this, macrophage and smooth muscle engulf the whole lipids. And finally, what happens? That the smooth muscle proliferation, collagen. Now this smooth muscle is not the normal smooth muscle. These are activated smooth muscle now. They have a capacity of forming this extracellular matrix. So smooth muscle cells, extracellular matrix, they are forming the cap, fibrous cap, right? You can have intracellular or extracellular lipid debris. You can have collagen, which is this one. Lymphocyte is also there, inflammatory cells. So we have a full cascade of atheroma. This is what is there in the book, and you can see it one by one. And this again, why I said that why neutrophils are not coming, because we have MCP1, which is monocyte chemoattractant protein 1, which actually secreted by monocyte, and this goes up, and specifically it is only attracting monocyte, not neutrophils. That's the reason why in this area there are larger amount of monocyte and some lymphocyte. and this monocyte, they are activated, and now they are engulfing more and more lipid. Okay. Now we are done with the pathogenesis. Any questions regarding? Yes. Yes. They are basically a cytokine which are being secreted by monocyte. So it's a vicious cycle. Monocyte, they are oxidizing this LDL. When the LDL come in, it is not oxidized. This monocyte oxidizes them. Then it also activates macrophage. So it's a cycle. This oxidized lipid, what you call LDL, they stimulate macrophage. Macrophage starts secreting interleukin-1, tumor necrosis factor, MCP1, right? So these are all. Then also growth factors. Growth factors are also produced, and these growth factors, they are platelet-derived growth factor, transforming growth factor alpha, fibroblastic growth factor. So these growth factors also help in forming newly formed blood vessels, right? And they also form proliferation of smooth muscles. So smooth muscles which are there, they are dividing itself because of the growth hormones, growth factors, right? Is it clear now? So more and more things are being formed, and atheroma is increasing in size.
Excuse me,
Yes.
but how come smooth muscle can migrate really in the blood vessel, like in the lumen?
This is what I said. They start secreting growth factor, right? And this is a propensity of these all cytokines and growth factors that they allow smooth muscle to come from the media, and they also recruit from the lumen. And when they are coming from the lumen, basically they are precursor smooth muscle. They are not a normal. They are the media smooth muscle. When they go up, again they are being modified by the cytokines and growth factors to make extracellular matrices, right? Now this one, this is called macroscopic feature of fatty streaks. And you see, usually they are seen in the intima. These are the intima, ostia, sorry, not intima, ostia, means opening of the blood vessel. So at the area of the ostia, you will see a fatty streak here, and you can even see this thing in a very early stage, like 1 year, even of 1 year child. And it is always seen up to the age of 10. Then it depends how much amount of lipid you are taking. So it is just like 1 or 2 layer of macrophages, lipid engulfing macrophages, or macrophages, right? Lipophages, sorry. So initially in a fatty streak there are only 2 or 3 layers, and then finally it increases in size. It depends how much you are taking lipid. And finally what happens? The plaques are formed. This is called atheromatous plaque. And in this portion, this atheromatous plaque becomes ulcerated. This shows only ulceration without thrombosis. This one is ulceration with thrombosis, right? Now this is a histological picture, cut section. This is a recent trichome in which you can see this is F is basically a fibrous cap. Blue because mesenteric trichome stained blue with the Fibromuscular. This is a core in which lipids are there. You can see inflammatory cells here, and this is HNE, so you cannot see inflammation here. But you can see one thing, in an elastic stain in the other slide, this elastic stain gives yellow color to the sclerosis, and then you can see that here you can see internal elastic lamina and external elastic lamina. But down here, because of this atherosclerosis, it has pushed down and narrowed the media. You can hardly see media. So by narrowing down this media this much, there is a weakness occurs in the vessel wall. And the aneurysm usually, they come from this area because they are so much weak, and they usually bulged out as an aneurysm. Next topic is aneurysm, so we will discuss the whole thing there, right? This is HNE, in which you can see This is the core. This is most of this inflammatory cells. This arrow are pointing at newly formed blood vessels, right? In the plaque, and this one is calcification. So you can have a calcification with or without. Atheroma can have calcification, cannot have calcification. Depends how much big it is. Now these are two sections of a coronary artery. In the first one, you can see a rupture here, but there is no thrombosis here. They say that they have taken this thing because the patient died abruptly. So when they take the section, there was no chance of thrombosis. But in this one, there is a rupture in the atheromatous plaque, and the thrombosis actually occurs here. And this thrombosis, what it does, it has blocked the whole coronary artery. And the area after this one was ischemia. And definitely, if there is ischemia, then the whole cascade of heart attack, right? Ischemic heart disease which we will be discussing, inshallah, next week. Here, it's very important slide. There are two plaques. One is vulnerable, and the other one is stable. It is vulnerable because it is a very thick fat, thin fibrous cap, lot of inflammatory cells. You remember this inflammatory cells secretes MMP. What is MMP? Matrix metalloproteinase. These metalloproteinase actually kills the collagen, and it helps in rupturing the cap, right? And here it's so thick that it is, and the inflammatory cells are very low, so the chances of rupture is very low here. Even the lipid content is also low, right? So what happens then? Nature history of atherosclerosis. Either it's a slow evolving process. It usually takes decades to develop a well-formed big atheroma. Lemon occlusion of the artery leads to ischemic injury, we all know. Weakening of the media and the vessel wall leading to aneurysm, we also know, aneurysm as I told you. Formation leading to stasis, thrombosis or rupture. If the vessel wall of the aneurysmal vessel is so weak, it can rupture. What is acute changes? Rupture, fissuring, erosion and ulceration. Once there is ulceration, they can have hemorrhage into it, they can have thrombosis, and finally embolism. And if the whole atheroma is embolized, it's called atheroembolism. The whole thing is going into the body. So almost we have discussed this thing before. It's a normal looking artery, and then it changes into fatty streak. This whole thing we have discussed already. Then it changed into fibrofatty plaque, this one, and finally it's advanced vulnerable plaque. It has almost occupied 70% of the coronary artery lumen. So if 70% are being occluded, then the patient may develop angina, which is called stable angina, because still there is space here. So the patient will feel pain when they walk or do some exercise, and they feel pain because it's still 70%. If it is 90% like this one, it can even cause unstable angina. Even lying down, the patient will feel pain. Right? Here, if you give nitroglycerin, patient the pain is gone, because that nitroglycerin will give dilatation of this vessel, and it gives some space, and ischemia is gone. So here, it can cause aneurysm, and they can rupture, or this ulceration or fissuring can cause thrombosis, occlude the artery and cause myocardial infarction, or critical stenosis, as I said, unstable. Now we have complication of atherosclerosis. What are those? Myocardial infarction, if it is completely occluded; cerebral infarct or stroke, if it is in the circle of Willis; cerebral infarct, stroke; aortic aneurysm, more difficult and common. Normally, aortic aneurysm is abdominal aortic aneurysm. Abdominal aorta are more prone to develop. Otherwise, thoracic can also, but usually aortic aneurysm. Peripheral vascular disease, you can have a gangrene of the leg when the main artery, popliteal artery, is blocked, and probably we'll be having a case of it. So, gangrene, the artery is blocked, so you had to open that one to get rid of it, and especially in the diabetes patient, if it is blocked, then it's a big problem. You have to cut the whole leg. Ischemic bowel disease, sudden cardiac death. This is another big problem. Chronic ischemic heart disease. So this two topic we'll be discussing fully in the next week, inshallah, and then ischemic encephalopathy. So these are the complications. And if you have any questions, yes. Fibromuscular? Intimal. Actually, usually what happens?